They're usually a mess. And if I'm all stressed out, and if I'm having trouble breathing, what's my heart doing? It's usually beating pretty fast. So, in terms of treatments, if the patient presents and they did not stay home for their first 6 hours, because you only have a short window to do certain treatments, when they arrive, one of the first things you want to do is put on some oxygen. Because typically, if the patient's having pain, oxygen is not getting to the tissue. Okay? So the patient's feeling pain with an oxygen deficit. And we usually typically start with 2 to 4 liters. We usually start with 2 because we don't know the people. We can go up to 4. What's the most you want to run a nasal cannula? 6. You really don't want to go higher than 6. It's not comfortable for the patient. It dries out their nares. If you need more than 6, you have to switch over to a face mask or a tent. You try to get the patient to assess their pain, if possible, on a scale of 1 to 10. Some patients will say 11, 12, 15. You go with nitro. You know how to give nitro. You give it under the tongue, wait 5 minutes, reassess the pain, see if they can have another. They can have 1 every 5 minutes, times 3. What do we go to next if the patient doesn't get relief after 3 nitro? Drip, IV nitroglycerin. We also give morphine. Morphine helps with the pain. It helps with breathing. Morphine is a wonderful drug. We can reverse it very easily, and it's not expensive. Aspirin, typically the patient would have been told to have taken the aspirin way back here at the beginning when they called 911. Or sometimes patients just know to take an aspirin because they've been told that by their doctor. We put them on ECG monitoring and take a 12 lead as soon as possible, and we repeat them every 8 hours. Now, let me just digress for 1 second. This is a patient who comes into your ER or to your office complaining of chest pain. What would we do differently if the patient came in unresponsive and you think that it might be a heart attack? They clutched their chest and went down. What would you do differently in this sequence? Rather than start with oxygen, give morphine, give nitro, what would you do first? You want to put on a monitor. You want to put on a monitor or an AED as soon as possible. If your patient's unresponsive, I want to, Annie, are you all right? Look, listen, and feel. Call for an AED. Why? What is the difference? Why don't we start with oxygen if somebody's unresponsive?
May not be breathing.
Right, they may not be breathing, so popping on a little bit of oxygen is not going to help them.
You want to know if they had any type of like ischemia or pain or injury?
Absolutely. You need to know. You need to know what rhythm they're in. You need to know if they're wiping out right before your eyes. So I need information that the patient can't give me. I need to know, most importantly, are they in VFib? Because if they're in VFib, what do I have to do within 10 minutes? DFib. I've got to reverse this. I can't take time to intubate them. I can't take time to put in a line. I have to know I have VFib and shock. Okay? Because I lose 10% of prognosis every minute. So as soon as I find I have VFib, I shock it. My chances are best during the first minute. They dwindle very quickly over 10 minutes. Okay? In 5 minutes, I'm at 50-50 chance of survival. Okay? So I need to know. I don't have time to intubate. So the board question will be something like, what will the nurse do, or what does the nurse plan to do if the patient comes in complaining of chest pain? You want to give oxygen as soon as possible. If they come in not complaining, unresponsive, you want to start CPR and get information. Get an AED to say shock advised, or put them on a monitor and find out for yourself and shock. Okay, see the difference between the patients. So be careful as you approach board questions. Timing is everything, and the scenario is important. How did your patient present? Okay, and take a chest x-ray. What's a chest x-ray going to show us? Why do I want a chest X-ray?
Size of the heart.
The size of the heart, okay, so it's gonna give me information about history. Okay, if I have cardiomegaly, that didn't happen overnight. Cardiomegaly is a chronic illness. What else? What's the chest X-ray gonna get me? What do you see on chest? See the heart?
Lungs.
Lungs, what's the status of the lungs?
Do they have fluid?
Do they have fluid? Is the patient in pulmonary edema? If they're in pulmonary edema, they probably have some history of congestive heart failure, okay, which is left ventricular dysfunction. So it tells me something about the heart. What else? Go
Damage
ahead. Pardon me?
from the heart.
You can't see damage on a chest X-ray, nor can you see wall muscle motion. But you can see if the lung is collapsed. I can see if there's a midline shift.
Can you see stents?
Pardon me?
Like stents they have in place?
Yes, you can see if they've had previous surgeries. Exactly. You can see clips and stents and all kinds of things. So the chest X-ray is important because it's going to give us some insight, but it doesn't tell us. Remember, a chest X-ray is a snapshot also, just like the 12 lead. It's not going to show you motion, and it's not going to show you damage. You do other tests for that. Okay, you're in the ER and you're going to order labs. We usually call it like a rainbow because we're going to draw one of every color tube and send them. But most importantly, I need to know, are they leaking cardiac enzymes? And cardiac enzymes don't tell me anything if I just have one set. Why?
Gives you a baseline.
Go ahead, Kate.
It gives you a baseline.
It may give you a baseline, but if, say you draw your cardiac enzymes and they're high, what does that tell you? Right, that there's some damage, but where are we in involving my MI? Is it over? Did it just start? You can't tell from one point, right? You can tell that they're having an MI or that there was damage done, but you cannot tell where they are with one point. That's why we trend things. So I draw my next set in 8 hours, and my number is yet higher. So what is that telling me?
More damage.
Right, more damage has occurred, they're still evolving an MI. What if I draw the next set and it's lower? Right, the event has finished and now they're resolving. So you need 3 points to determine where your patient's going. If I take the third set and it's still higher, what do? Draw more. Exactly, you're going to follow again. Okay? So we tend to do cardiac enzymes Q8 times a week. We look at at least a 24-hour period, and then see. If your patient continues to have pain, you continue to draw. Okay. We expect the patient to have dysrhythmias. Why? Katie, why do you think somebody's going to have a dysrhythmia if they're having an MI? Right? There could be damage to the heart, so the electricity is not going to flow normally. But what else? What will cause a dysrhythmia or what will cause PVCs? Right? Pain. Pain will do it. Exactly. I'm going to get tachy because I'm in pain. What's going to cause you to throw, say, PVCs or go into VTAC? Pardon me? Irritation secondary to what?
Damage spots with throat, extra impulses.
Right. So if the patient's had an MI, there are probably tissues that have died, and they work as irritated spots. And they're going to be foci that are going to cause the heart to beat irregularly. Most commonly, we see hypoxia, though. Why would we have hypoxia? Why would the heart muscle not get enough oxygen? Because it's not pumping properly. If I've had an MI, my heart is not pumping properly. Remember, the heart has to feed itself. The heart feeds all the other body parts, but it also has to feed itself. And if the heart doesn't pump properly, the heart doesn't get fed. So if I'm not getting oxygen to the heart muscle or the heart tissue, I'm going to start growing PVCs. I may wind up in VTAC. So it's a vicious cycle. The arrhythmia causes the heart to not beat properly. If the heart doesn't beat properly, it doesn't get enough blood. If it doesn't get enough blood, it doesn't beat properly. Doing a vicious cycle. So you need to treat dysrhythmias as protocols, which means we put the patient on antiarrhythmics. What electrolyte are we checking? Potassium. We're gonna evaluate our labs and our 12 leads. We're gonna think about thrombolytics. What are thrombolytics? Right, they break up clots, clot busters, thrombolytics. They are not anticoagulants. They are not antiplatelets. Aspirin's an antiplatelet. Heparin and Coumadin are anticoagulants. These are medications that break a clot that's existing. Yes, sir?
What's Plavix?
Plavix, Plavix, I believe, is an antiplatelet. I think so. It makes your cells like Teflon. So it coats them so that they slide past each other, they don't stick. But it is not a clot buster. Okay, aspirin's an antiplatelet. Anticoagulants, heparin, integralin. We're gonna come back to thrombolytics. Vasodilators. Okay, you know nitrates, you know nitroglycerin, you've heard about it before, you've done it on farm. It's important to recognize, we're gonna spend a lot of time on this concept of vasodilation and vasoconstriction. Because as you mentioned, Emily, the patient in neuro who is having pain, as we give morphine to this patient, it's gonna have an effect on his vessels. And it's going to allow for more carbon dioxide to build up. Carbon dioxide causes vasodilation. We're going to spend a lot of time on the heart as a pump, the vessels, and the blood as volume in every system. So one thing that affects the dilation of your vessels are nitrates. We give nitrates a lot, but we have to be careful with them. Our goal with using nitrates is to decrease the workload of the heart. We do that by decreasing preload, decreasing afterload, and decreasing the pain. How does that work? How does nitrates, nitroglycerin, decrease your preload, your afterload? Explain it to me. You said it, Katie? When it dilates your vessel, what does that do to the pressure? It decreases it. So I have a vessel that's very tight, okay? I'm stressed. I'm having pain. My blood pressure's high, my vessels are tight. I take a medicine that relaxes my vessel. It drops my blood pressure, okay? Makes the blood flow smoothly. But there's no pressure against the walls. What does that do to my venous return? The volume of blood has gone down to my feet, gone to all my organs, now it's on my way back to my heart. What happens to that volume? It decreases, right? Because if my pressure's low, it's going to take its time getting through the body. If I have decreased blood coming to the heart, that's decreased preload. See how that works? So by dilating those vessels, I drop the pressure. When I drop the pressure, the volume of blood going through the heart doesn't surge getting back to the heart. So there's decreased amounts of volume of blood getting back to the heart. I have decreased preload. Remember, volume in is volume out. So if I have decreased amount of volume coming to the heart, what can you tell me about the afterload as the heart squeezes and pushes blood out?
It's got less resistance.
There's less resistance. First of all, I have less pressure coming from the heart itself, but those vessels are now dilated. If they're open to receive. They're like vessels, or big chambers that are open to receive blood. So it makes it easy for the heart. The heart doesn't have to squeeze as hard to dump the volume of blood to an open vessel than it does to a vessel that's constricted. So by giving a nitrate, I decrease the preload, so the heart doesn't have to work as hard. I decrease the afterload, the heart doesn't have to work as hard. And I decrease the pain, so there's less O2 demand. But what's the, remember I told you every action has an equal and opposite reaction? Mm-hmm. Every time I give a med, I'm going to have some cost somewhere. What's the cost in all of this as I give the nitrate? I want to give the nitrate. Right, it tanks the blood pressure. So you've got to be careful that when you give a therapy that we don't overshoot. We want to drop the blood pressure. We don't want to drop it too low, because if I don't have enough venous return, what happens then to my cardiac output? it drops also.